Huntington's disease, or HD, is a neurodegenerative disease that affects the basal ganglia situated at the base of the forebrain. The basal ganglia's main function is to control voluntary movements. Chorea, derived from the ancient Greek word chorea, meaning dance, characterized by jerky, uncontrolled movements, is a disorder that all HD patients develop over the progression of the disease. Other symptoms include lack of concentration, slowed speech, depression, and dementia. It currently has no known treatment. The cause of HD is a lengthened CAG triplet repeat sequence on the Huntington gene on chromosome 4. The table on the right is a legitimate medical report outlining the severity of the Huntington phenotype based on the number of CAG repeats in the patient's Huntington gene. CAG codes for the amino acid glutamine, so essentially, patients who produce abnormally long Huntington proteins have a polyglutamine disease. The exact method of neurodegeneration in the basal ganglia by the abnormally long proteins is mostly unknown, but the effect is obvious. These images are from an advanced case of HD. HD is an autosomal dominant condition, which means regardless of sex, an individual needs only one copy of the affected gene to show the phenotype, and offspring of an affected individual have a 50% chance of inheriting the condition. For this reason, there are strong motivations for individuals at risk to pursue a genetic test to help in decisions relating to reproduction or career planning. There are various situations in which an individual would choose to take a genetic test. In all cases, they must be over the age of 18. If the individual has a family history of HD, they are eligible for a predictive test, which determines whether they carry the faulty gene. If a patient has already been diagnosed with HD by a neurologist or a neuropsychiatrist, then they're eligible for a diagnostic test that confirms or denies the suspicion of HD that was based off symptomatic evidence. Testing of this type requires a blood sample to be taken. Couples who are at risk of carrying the abnormal Huntington gene are often interested in ensuring that their offspring are free of the condition. Without confirming whether or not they do in fact have the condition, every birth is like a coin flip with the devil that is Huntington's disease. An in vitro fertilization provides a simple way to test an impending embryo during its early fetal stage. This method, called pre-implantation genetic diagnosis, occurs while the fetus is only 8 cells in size. One cell is removed from the fetus under a microscope and examined. Women who are already pregnant can have various forms of prenatal testing for the disease, including chorionic villus sampling or an amniocentesis. The former occurs quite early in the pregnancy and involves a sample of fetal cells to be taken from the lining of the placenta. The latter can happen much later in the pregnancy and involves a sample of amniotic fluid to be extracted from around the fetus. Once a sample of blood, fetal cells, or amniotic fluid is extracted, a type of DNA sequencing called gene probing is carried out to determine whether the sample contains the faulty Huntington gene. Gene probes are single strands of DNA occurring either naturally or created artificially that are complementary to the known sequence of bases from a specific gene. Prior to gene probing, the DNA from the blood, fetal, or amniotic sample is separated out using a buffer solution. The resulting DNA is heated up to denature the double strands and separate them into single strands. The gene probes, with sequence GTC, complementary to the CAG repeat sequence on the Huntington gene, are given radioactive tags before being inserted into the sample of DNA. The complementary gene probes combine with the target sequence, and the hydrogen bonds between nucleotide bases holds the strands together tightly. The loosely unattached gene probes are filtered out of the sample, leaving only the complementary probes behind. The sample is put under a radioactive scanner to observe which gene probes were an exact match with the known base sequence. By assessing the length of gene probes attached to the single strand of DNA, the length of CAG repeat sequences can be inferred, and the degree of the condition can be determined. The ability to test an at-risk individual for the abnormal gene has brought massive benefits to society. The test obviously has tremendous psychological effects if the results are positive, but living with uncertainty causes many other forms of stress, analogous to the stress of not knowing who your parents are, or the stress of not knowing whether you see a loved one again. Facets of life, such as career planning or reproductive planning, may depend on whether the abnormal gene is carried. A positive test result can help with making hard decisions, while a negative test result can relieve anxiety and stress. Individuals who have been diagnosed with HD through symptomatic or neurological observation can use the test to confirm or deny the diagnosis. Confirmation of the diagnosis means that the patient can use treatment known to slow down symptoms caused by HD, while denial of the diagnosis means that different avenues must be considered. The affliction that led doctors to believe the patient's condition was HD could be a treatable condition. In that case, knowledge that the HD diagnosis is wrong means that a true diagnosis can be found and legitimate treatment can be commenced. Couples who are at risk of carrying the HD gene can use genetic testing to ensure that the condition is not passed on to their offspring, and in vitro fertilization tests each fetus systematically until a normal fetus is found and implanted into the mother's uterus. Women who are already pregnant can choose to have a CVS or amniocentesis to determine the genetic condition of their baby and can possibly choose to terminate the pregnancy. A termination could benefit the future family who are unable or unwilling to parent a child which they know will develop degenerative fatal symptoms in their lifetime. Otherwise, the knowledge of the condition can prepare the family or the baby can receive symptomatic treatment early in life. The ethical debate surrounding genetic testing of Huntington's disease basically comes down to who should have access to the results and what should be done with them. A positive test result for an individual is an extremely personal and inexorable discovery that could have impacts on job opportunities, health insurance, and happiness in marriage. There is little evidence that genetic tests are currently being performed in Australian workplaces, although there seems to be a move towards routine genetic screening for certain jobs. The Australian Law Reform Commission described the use of genetic testing as still largely of theoretical concern. This contrasts with the United States, where a survey conducted revealed that 15% of major companies use genetic testing as part of their employment process. This could be caused by the fact that US employers have a legal responsibility to provide health insurance for their employees, while in Australia they do not. As of 2017, a parliamentary inquiry is underway into Australia's life insurance industry, which has raised several issues surrounding genetic discrimination. Australian insurers who have access to genetic information about their clients can increase premiums if they know the client is at risk of developing a disease such as HD. From a study performed by the European Society of Human Genetics, out of the 3 countries, Australia, UK and Canada, the UK have the most comprehensive protection against genetic discrimination in insurance policies. British insurance companies are not allowed to use predictive genetic test results for insurance policies below the sum of £500,000. Above this figure, companies are allowed to use genetic tests as sanctioned by the Government Advisory Committee, and until May 26, 2017, only Huntington's disease testing has been permitted. The ethical debate surrounding employment and insurance boils down to confidentiality and financial fairness of the individual versus the company. Many would argue that individuals affected by HD should receive all insurance benefits and employment opportunities to that of a normal individual, based off the fact that life with HD is hard enough as it is. Companies argue that their own financial situation is of utmost importance, and the misfortune of specific individuals is none of their concern. The other major ethical debate revolves around the termination of pregnancy and pre-implantation genetic testing. Termination has many emotional implications attached, but bringing up a child with a known untreatable fatal disease to some is worse. Many argue that 30 to even 60 years of life prior to developing HD makes it worth continuing the pregnancy. Everyone's views are different, and it comes down to the couple's personal philosophy at the time. Pre-implantation genetic testing has similar issues. The process involves the artificial fertilization of many fetuses, with only one fetus going on to become an embryo. The debate involves the question, where does life start? Some would say that 8 fertilizations with only one implantation is a murder of 7 babies, while some argue that the non-disease inheriting baby has been given a blessing to live its life without fear of developing Huntington's disease.